So, uh, dear friends, dear colleagues, it is a truly great honor to hold this combined neurosurgical webinar, which is organized by a joint Asian Congress of Neurological Surgeons and International Rhoton Society. So it's a joint webinar which is containing many interesting lectures by various topics covering aneurysm, interhemispheric approach, and intraoperative ECOG guided precision resection of epileptic lesions. So we welcome you all. And I will give the floor to Professor Kato to welcome the participants and other colleagues.
Thank you very much. I think Brazil must be, 6 a.m. in the morning. So thank you very much from such early in the morning. So we are so honored to have a great webinar with Rhoton Society colleagues. So I think maybe we can learn a lot from you and from us. Thank you very much. Use up, please.
Yeah. Let me introduce a first lecture speaker of our webinar, who is Carolina Martins. She's from Federal University of Pernambuco, Recife, Brazil. We'll be talking about microsurgical anatomy and aspects of neurosurgical interest. So if she's online.
Yes, I am. But Dr. Dishod, let me break a little bit the protocol and give the floor to our president at the International Rhoton Society, Professor Wen, that joined us this morning. I think he will have to run out to the OR, so this is why I'm breaking protocol.
Yes, sure.
Oh, hello, good evening to Japan. And here is good morning, 6 a.m. It's an honor to be part of this important symposium. I'm very glad very honored to have a cooperation between the International Rhoton Society. You know, we are disciples of Dr. Albert L. Rhoton Jr., the late Dr. Rhoton, who promoted tremendously the anatomical knowledge worldwide. And this cooperation with Asian Congress on Neurological Surgeons is absolutely important because neuroanatomy applied to microneurosurgery is the foundation of a successful microneurosurgery. We are very honored to be part of it. Thank you so much for the invitation.
Thank you.
Thank you so much, Dr. Wen.
Thank you, Dr. Dishod, for that. And I will share my screen while I say a little bit more, because at the International Rhoton Society, we are a family, and Dr. Wen is my elder brother, and he taught me everything about working in this area. My patients benefited from his wisdom and his experience, and I want to register that before I start. So it's very good to be here among friends, and especially to speak about this area, which demands that we have our anatomy very ready, right? To operate in the medial temporal region, we have to be okay with our anatomy, not only of vessels, dura, bone, but mostly of the brain. And this is what we do at the International Rhoton Society, right? We study the anatomy that makes our surgery safer. And this is why I'm very glad and happy and honored to be here today. And from all these things that I mentioned, I'm going to touch little points in the neural relationships in this area. And we will start in this view, very anatomical view, in fact, where the medial surface meets the basal surface, so the border between the two, because this is our focus of study today, and it's our focus of interest in surgery. And although we say medial temporal region, many times we come to this area not to chase temporal structures, right? Because the parahippocampal gyrus, which is the border between these two areas, is in fact part of the great limbic gyrus. So we many times use temporal structures. We pass along temporal surface to reach limbic structures. We are dealing, in fact, resecting limbic lobe. So in this border, a border usually keeps characteristics of both sides it divides. It's the same here. The parahippocampal gyrus that seems to be formed by the isthmus of cingulate gyrus and the lingual gyrus, and that we know turns on top of itself in front to form the uncus. It retains a nice feature that we know about the medial surface, which is the medial surface has several layers, different layers arranged on top of each other. This is what we understand of the medial surface. And in this area, it is the same. We just don't notice. Why don't we notice? Because the layers here are thinner and they are not aligned. They are misaligned. So if we get close to this area, to this region of the parahippocampal gyrus that goes all the way to the collateral sulcus, already on the basal surface, and to the rhinal sulcus, many times they are continuous between each other. Sometimes it is continuous with the impression of the rhinal sulcus. And turns to make the uncus and has an anterior, a posterior surface, a medial apex, and extends all the way to the endorhinal sulcus at the level of the optic tract and the anterior perforated substance. When we pull on this area of the parahippocampal gyrus, which is the subiculum, we see that the layers are there. And very thin layers. The very first layer is separated from the subiculum of the parahippocampal gyrus by a sulcus. If we notice, the sulcus is the same as it is here. Here we say callosal sulcus. Here we say hippocampal sulcus, but it's the very same one. And the hippocampal sulcus continues in front and meets that area where the uncus, where the parahippocampus turns on top of itself and becomes uncal sulcus or uncal incisura. So an uncal incisura is an enlargement of the hippocampal sulcus. And it separates subiculum from this first gyrus, which is the dentate gyrus. Very complex gyrus, interlocked with the hippocampus on the other side, and we will be seeing it. And we are not seeing the dentate completely. We are just seeing the margin of the dentate. So the dentate is separated from now white matter by another sulcus. This is the fimbrodentate sulcus, and above that is the fimbria. Fimbria is, like we know, a part of the fornix, and we all remember that the fornix and all its parts form one lip of an embryological fissure, which is the choroidal fissure, that has two ends, one here, another here. This one we all know well. This is the enlargement of the choroidal fissure. This is the foramen of Morrow. But here we have the inferior choroidal point. Very important landmark in surgery for the medial temporal region. So if we look to the parahippocampal gyrus all the way to the choroidal fissure, we will see layers as well. But those layers are not aligned. They are misaligned like that. And this idea that the layers are misaligned help us a lot to understand why we see some structures on the cisternal side and others on the ventricular side. So we are looking at the right side on both, but here we are looking more to a cisternal side and here to a ventricular side. And we see subiculum again. Subiculum is here, both sides. We see the margin of the dentate, but on the ventricular side, we look at the interconnected gyrus, which is the hippocampus proper. Dentate plus hippocampus is the hippocampal formation. And please notice that the hippocampus goes along the medial wall of the temporal horn, just medial to an elevation, which is hard to notice when we are dealing with 2D, but trust me, there is an eminence here and a trigone here, a little more elevated, because they have to deal with the depth of the collateral sulcus. So collateral eminence, collateral trigone. And we see phonics on both of them. Here, the choroid plexus have been kept, the thalamus have been removed on the other side of the choroidal fissure, but we see phonics on each side. And now we understand why we don't see the same structures. They are misaligned, right? And please notice the uncus. We said anterior surface, posterior surface, medial apex of uncus. Inside they have a very important correspondence. The anterior surface of uncus corresponds to the amygdala. The upper part of the posterior surface of uncus above the uncal notch is related to the head of hippocampus, which its internal digitations, while the lower part is a lip of the parahippocampal gyrus, as we have just mentioned. We can even improve this exercise to look at the ventricle, look at the cyst, and see the parts of those structures. Very important if we are willing to resect them. And here we have the right hippocampus. We see the head. The head is uncovered by choroid plexus. The head is bald because the head of hippocampus ends at the inferior choroidal point. Remember the inferior choroidal point? So it ends there, and there is the point where the choroid plexus starts. Also, it's the point where the anterior choroidal artery enters the ventricle, finishes its cisternal segment, starts its plexal segment, and it's the point where this vein comes out of the ventricle through its roof to meet the basal vein. This is the inferior ventricular vein. So this is the limit between the head and the body of hippocampus. From that on, we have body. And the body of hippocampus, they do turn. The hippocampus is a curved structure, curved because the temporal bone and the limbic lobe, when they are growing up, they meet the greater wing of the sphenoid, cannot go forward, cannot grow forward, so they turn medially. It will turn medially on the head and on the tail of the hippocampus. And every time the brain turns, there is a sulcus. If you notice, please, this is the parahippocampal branch, a secondary branch of the collateral sulcus. We don't see that in surgery, but that is the marking that this tissue has folded. And then we have to use a surrogate marker, and a nice surrogate marker is the wall, the anterior wall of the atrium that we know is formed by the thalamus. So the thalamus tells us the anterior wall of the atrium tells us that we are reaching the tail of the hippocampus that seems to be ending around this area. So we can even improve our view and meet the limits of the hippocampus. So the hippocampus is not, as we mentioned, a straight structure. This is an important point. It is turned along the head and turned along the tail in a curved disposition. But can we keep going on and look at the basal surface and see the structures that we are mentioning? Can we see the layers that we are mentioning? Let's see. We said that our limit is rhinal sulcus or rhinal incisura, limit between archicortex and neocortex. The new part of the temporal bone makes its limit from the limbic structures. The collateral sulcus is on our limit. Then we have the rest of the basal neocortex structures. Can we see above? Well, if we look at the most medial part of the parahippocampal gyrus, we don't have layers there, right? We have a space. This part forms the shelf, lower shelf of this transverse space, which is the transverse incisura of the brain, and contains a cisternal compartment, the ambient cistern. So there's no layers on top of this, only space. But if we come to the most lateral part of the parahippocampal gyrus, then we will see dentate and we will see the interlocked hippocampal proper. They will be there with the fornix on top, and that will take us to the choroidal fissure. This will be arranged like that. And like we said, the hippocampus is on the medial part of the floor of the temporal horn, while there is an elevation given by the depth of the collateral sulcus on the most lateral part. If we can even finish up looking where this basal surface is supported, if we look at this area down, we can remember that the middle fossa is not all bone, right? It is bone up to the temporal crest. From that point on, we have dura, tentorium is there. The limiting is the sulcus for the superior petrosal sinus. So this area, temporal occipital area, will be supported by bone and dura. And if we have a look at this area, we will be able to know where we are, and we will be able to translate this understanding for us in surgery. So from the temporal crest to the front, it is in fact falling a little bit downward into the temporal fossa. Behind that, it is a little higher, supported by dura. And this projection of the temporal crest comes from just posterior to the uncus all the way to the temporal occipital incisura in an oblique line. Anterior to that, we have bone supporting this area. From that part on, we have dura. And if we look where our brain is, we can have another glimpse that will illuminate the way we see our imaging. I think that is what I have time for now. We are going to speak a little more about imaging with Anna. And if you are interested in knowing more about the anatomy of this area, we have just put out two little papers on the subject. Maybe you get interested into reading. Thanks very much for having me. It's a pleasure to be here with my friends, and I turn over to the floor.
Thank you. Thank you so much, Carolina, for this wonderful, very informative anatomical lecture. It gives us very detailed explanation of medial temporal lobe anatomy, and it's very beneficial for performing the surgeries and making this our surgeries safer. So I will ask from the audience and moderators, Professor Kato, if anyone has any questions from the first lecture of Dr. Carolina Martens.
You can listen about Dr. Anna
Okay.
report.
Okay, so
Carolina,
we'll just...
congratulations. Thank you so much.
Thank you again, and I will give the floor to Dr. Anna Craig-McQuaide to her lecture about radiological anatomy.
Oh, hi, good morning. Can everybody see my slides? Sorry, one moment. Sorry, I'm using a borrowed iPad because I have a problem with my computer. So if you just bear with me one moment, I should be able to start the slideshow. So
No
is
problem.
everyone able to see a
Take your
slide
time.
now?
Yes.
Okay.
Yes,
We do
visible.
see
Thank
your
you.
screen.
Thank you. Good morning, good evening. Thank you for the opportunity. My name's Anna. I'm a registrar at the INS in Glasgow. I am honoured and humbled to be speaking amongst such esteemed speakers. I'm going to speak for the next 12 minutes or so about the radiological anatomy of the mesiotemporal lobe. Professor Martins is a very hard act to follow, but I will do my best. So we've already seen the anatomy demonstrated beautifully. So I'm going to talk a bit more about what it looks like on MRI imaging, essentially. So as we know, the components of the mesial temporal lobe, we have the amygdala, the hippocampal formation with the corneomonas, the dentate gyrus, and the subiculum, and then the parahippocampal gyrus that we can divide into the uncus and the entorhinal and perirhinal cortices. So here, just as an outline to start briefly on axial section, we see the uncus anteriorly, the hippocampus, and then we go back into the parahippocampal gyrus, which is continuous posteriorly with the lingual sulcus, and which is bordered laterally by the collateral sulcus. The lingual gyrus, apologies, I think I said lingual sulcus just then. So here on this coronal section, we can begin to see the sort of classical rolled up Swiss roll cake appearance of the hippocampus, and we'll look at this in a bit more detail on some 7 Tesla images in a few slides. And here, the sort of classically described sagittal section of the hippocampus looking more like a sausage, but again on 7 Tesla we'll see it looking a bit more beautiful. So on this lower right panel we can see that on sort of modern good quality MRI we can see the subsegmentations of the corneomonas, and also see beautiful details such as these digitations here on the head of the hippocampus, which, as Dr. Martin said, is bare and doesn't have choroid over it in the way that the rest of the hippocampus would do. We can also make out things like the alveus, the beautiful white matter of the alveus, which we'll see in a moment in a bit more detail. So we've already seen this with Dr. Martins, but just briefly on this schematic in sagittal section, this stippled area here is the dentate gyrus, and then the more sort of striped area here is the corneomonas, and then the fimbria on top of that. So we're going to go on to a coronal schematic in this plane, this A to A line on the next page. So here we can see the dotted area is the dentate gyrus, sort of the filling of the Swiss roll cake, which then has wrapped around it the corneomonas, which we know can be divided into its 4 subfields. This arrow here denotes the hippocampal sulcus between the two, and then we come into the subiculum, down into the entorhinal area, the parahippocampal gyrus, and we would continue into the collateral sulcus. So I know we often appreciate comparative anatomy. This is just a bit of comparative gastronomy. On the left, we have from Pernambuco in the northeast of Brazil, bolo de rolo, which is a very delicious roll cake made with guava jam, which I enjoyed when I was doing my elective with Professor Martins in Recife. And on the right, we have the British chocolate Swiss roll cake. So that's just a little bit about what the cake that we think of when we see coronal sections of the beautiful sort of rolled up hippocampus. So these are just some coronal sections looking at the head, body and tail of the hippocampus. So starting here in the top left panel, if we go to the level of the interpeduncular cistern, then we're at the level of the head, and we can see the digitations on the head of the hippocampus here. The amygdala is denoted by this black square. And then if we move down to this bottom right-hand panel, the body is at the level of the mesencephalon. It's more ovoid and uniform, and as discussed, lies below the choroidal fissure. And the parahippocampal fissure separates the body from the parahippocampal gyrus. And then moving further posterior, we come to the hippocampal tail, located at or behind the mesencephalon, and adjacent to the crura of the fornices on this section. So this is an example of a 7 Tesla coronal image with 3 Tesla on the left for comparison. So you can see that on 7 Tesla, you can see the beautiful sort of dark, hyper intense myelinated white matter of the alveus sitting there on top of the hippocampus. And you can even make out the stratum radiatum lacunosa moleculare here, which we know is a good biomarker for early Alzheimer's disease. And you can also see reduction and loss of definition in the SRLM in patients with hippocampal sclerosis and epilepsy. So this is just another image showing how well we can resolve on modern imaging the normal hippocampal anatomy with the subfields of the corneomonas. Again, the white matter of the alveus nicely demonstrated here. The hilum, which is CA4 and dentate gyrus together, and again the SRLM and the subiculum. And this is again showing the head, body and tail on coronal section. So inset in the small panel, you can see a sagittal taken along the long axis of the hippocampus, and it's got white lines denoting where we're taking these coronal sections. So A is head, B is body, and C is tail. So here again, you can see sort of the digitations on the head. You can make out the alveus and the SRLM again and the hilum, and then the cake is a little bit flatter and more classical in appearance when you come to the body because you don't have the digitations. You can see the choroid here, and then you lose the definition a bit as you go back into the tail, and you can see the alveus sort of blending with the fornix there. This is some more 7 Tesla imaging. So I think I really like this axial section because you can actually see a seahorse, I think, here really beautifully. So you have the digitations of the hippocampus here anteriorly, and then you can really see Amon's horn very nicely here. And again, on this sagittal section, in other imaging, it looks like a sausage, but this 7 Tesla image really beautifully shows the shape of the hippocampus and its digitations. And this is a 3D rendering that this group did by manually segmenting out the hippocampus from their 7 Tesla imaging. And here on the head of the hippocampus, they've shown the internal digitations really, really nicely. And you can even see here the fimbrodentate sulcus. These are some more coronal sections of MRI. The top panel deals with the hippocampus and the bottom panel with the amygdala, and it demonstrates again how you can resolve very nicely the internal structures of these, and you can use modern software imaging to segment out the subfields of the hippocampus and the nuclei of the amygdala. So this is segmentation of the subfields of the hippocampus in a sagittal plane. And then moving on to talk about the amygdala a bit more, as we know, the amygdala can be divided into cortical and nuclear parts, and the nuclear part can be subdivided into 2 groups phylogenetically. And then again, this is just another demonstration of segmenting out the nuclei of the amygdala on coronal section imaging. So the parahippocampal gyrus, as Professor Martins beautifully demonstrated in the anatomy talk, can be seen here in 3 sections, in 3 planes, apologies. So this is just, again, to demonstrate, as Professor Martins already has, that you have the tentorium here, denoted by the red arrow, the parahippocampal gyrus. This yellow arrow shows the collateral sulcus, and this is the hippocampus proper up here. So this is, again, just another demonstration of the parahippocampal gyrus coming forwards into the uncus, the collateral sulcus there, and the lingual sulcus further back. I won't spend too long on this because I think Professor Martins already covered it very nicely. Another thing to mention, of course, about the radiological anatomy of the mesial temporal lobe is that from a white matter point of view, this is a very busy area, and there are a number of important white matter tracts passing through the mesial temporal lobe at the level of the Lyman insula and the piriform cortex. So I'm just going to talk for a few minutes about hippocampal sclerosis. So this is just a demonstration on coronal T2 and flare of hippocampal sclerosis. So as we know, sort of the primary signs we see in hippocampal sclerosis would be volume loss and increased signal or hyperintensity. And you can see a corresponding appearance of a more dilated temporal horn around that atrophy. And then we know that the secondary correlates of hippocampal sclerosis or mesial temporal sclerosis can include atrophy of the fornix and the mammillary body. And in some cases, hippocampal sclerosis can be bilaterally symmetrical in sometimes up to 15% of cases, which makes diagnosis more difficult to the naked eye because there isn't that striking asymmetry. And there's some interesting work about using artificial intelligence to detect those cases. These are just some high-resolution coronal MRI images that demonstrate that the different ILAE subtypes of hippocampal sclerosis can be nicely differentiated on MRI imaging based on differential volume loss in the different subsegments of the hippocampus. So in terms of imaging protocols for mesial temporal lobe imaging, it's essentially an epilepsy protocol, which I'm sure you're all familiar with. So you'd start with basic sort of T2 flare, coronal oblique that have to be scanned perpendicular to the long axis of the hippocampus, and then a 3D T1 weighted volume to look for atrophy and do your segmentation. And then spectroscopy, so reduced N-acetyl aspartate, indicating neuronal loss, and you can also do T2 relaxometry for quantitative measures of hippocampal T2 signal. And then in those patients with temporal lobe epilepsy who have normal structural MRI or who are so-called MRI negative, one would move on to doing functional imaging with FTG PET, looking for interictal hypometabolism in the affected lobe, and also hyperperfusion at seizure focus on ictal SPECT. There's obviously a wide differential of other lesions that can affect the mesial temporal lobe apart from hippocampal sclerosis, including infections such as herpes simplex, neurodegeneration, Alzheimer's disease, as we mentioned briefly earlier, neoplasms, typically lower grade neoplasms, and limbic encephalitis and other autoimmune conditions. Thank you very much for your attention and for the opportunity. I will finish there and stop sharing my screen if I can. Apologies.
Thank you so much,
Thank you.
dear Anna. It's a very, very detailed explanation of radiological anatomy, and we will give the talk to the next speaker, who is Professor Leila Darros from the São Paulo University, Brazil, surgical aspects of this region.
So thank you very much for the kind invitation. I just share my screen. Is it okay?
Yes, that's
It's
fine.
okay.
Okay, so thanks to the Rhoton Society, as well to the ACNS, Professor Wen and Professor Carolina. I'll talk about medial temporal region, surgical aspects. There are several variations of temporal lobe resection that have been described, all with good results. Yasser-Gil technique involves the transsylvian selective amyloidopancreatectomy. Niemeyer and Spencer's techniques are performed through the medial temporal gyrus. And with anterior temporal lobectomy, described by Spencer, and the selective anterior amyloidopancreatectomy, described by Niemeyer. The main difference among these techniques lies in how the ventricle is entered and how to access the medial temporal lobe. But depending on the lesion location, our surgical plan is going to be different. The choice of approach is based not only on surgeon's familiarity, but also on the location of the lesion. In this case, for example, when dealing with an oncom tumor, a transsylvian approach is often the most appropriate option. But if the goal is also to resect the hippocampus and to perform an epilepsy surgery, other approaches may be used depending on the specific case and surgical objectives. However, one common step among the techniques of mesial temporal lobe resection is opening the temporal horn. And how to enter the temporal horn, that's a quick question. In how to safely enter the ventricle, especially in cases where the anatomy is distorted or displaced by a tumor. The temporal horn lies around 2.5 to 3 centimeters from the temporal pole. There is a useful and thoughtful technique described by Dr. Wen in 2006 that can be applied. In most cases, the entry to the temporal horn is really straightforward. However, it may occasionally be difficult to locate when we have a tumor or anatomy distortion. So this technique advises you to direct our dissection toward the medial temporal fossa, changing the dissection angle intentionally and taking a slightly uncorrected trajectory. Once we reach the gray matter overlying the occipitotemporal sulcus, we direct our dissection more medially and more superficially. We can find also the collateral sulcus, and then we redirect our dissection in the direction of the ventricle. Medial to the fusiform gyrus lies the collateral sulcus, And it's a complete sulcus. It bulges into the temporal horn, forming the collateral eminence. That is another way to reach the ventricle. The most common surgery that we perform in the medial temporal region is the hypocampal sclerosis. And I'm going to present how we perform the surgery technique in our epilepsy center in São Paulo. This is our point of view. This is the surgeon point of view. So we describe a transchirurgical approach that incorporates the modifications of the transcranial technique. First, our patient positioning. The patient is placed in the spine position with the head rotated to the contralateral side. The malar eminence should be the highest point of the head, and we should avoid excessive extension because it may limit the posterior section of the hippocampus. It's really important to determine the optimal head position and rotation because we have to avoid damage to the temporal neocortex. So a third-degree rotation provides a straight corridor to the most posterior part of the hippocampus. Otherwise, we would damage eloquent cords, mainly in the left hemisphere resections. For the craniotomy, it's important to expose the angle of the zygomatic arch. After an interfacial dissection, the temporalis muscle is detached inferiorly from the zygoma. And the craniotomy is really similar to a classic pterygium craniotomy, but extensive exposure of the frontal lobe is not necessary. At a minimum, the Sylvian fissure should be exposed. Additional drilling of the sphenoid wing is not required, and then we perform a C-shaped opening of the dura mater. So now I'm going to show you how to reach the temporal horn and the temporal tip removal. So we begin with a resection around 2.5 to 3 centimeters from the temporal pole, following the superior temporal gyrus. We use that just to assure that we are in the 3 centimeters of the temporal pole. Here we use the ABK intraoperative ultrasound to help to identify the temporal horn. This is a simply supportive tool that we have in our hospital nowadays, so we may use it. We use an artery to be our posterior limit. We follow the dissection through the superior temporal gyrus. As I told you, a larger artery may serve as our posterior limit. We preserve the arachnoid membrane that separates the gyrus from the Sylvian fissure, up to when we reach inferior limiting sulcus of the insula. So when we reach the inferior limiting sulcus of the insula, we know that the temporal horn lies approximately 1 centimeter from this landmark. At this point, we are looking for the gray matter, as I told you with Dr. Wen's technique. It's not so easy to see in the video, but we may use also again the BK intraoperative ultrasound to confirm our approach and localize the ventricle. And we may also use a guidance by brain lab neuronavigation. And now we undoubtedly open the ventricle. Cerebrospinal fluid is flowing out. And the hippocampus, which forms the floor of the temporal horn, is now visible and is used as a landmark for neocortical resection. The next step is the temporal pole resection. So the temporal horn serves as a landmark for temporal pole resection. Remove all the tissue that is superior and lateral to the ventricle, anterior to the first artery that we preserved here. Care must be taken to spare any veins as well as the arachnoid of the medial fossa. Or any artery that is going to the most posterior part of the temporal lobe. So after we remove the temporal lobe, we perform the lateral disconnection and para-hippocampal gyrus removal. So after the removal of the temporal tip, we are going the ventricle exposed. The image shown corresponds to a previous technique when a larger temporal pole resection was performed, which made the visualization of the choroidal plexus and the inferior choroidal point easier. Nowadays, we're generally beginning with the lateral disconnection of the hippocampus up to the collateral trigon. And these lateral disconnections facilitates the mobilization of the hippocampus and help us identify the inferior choroidal point as a landmark for the amygdala resection, the next step. So we follow the collateral eminence for the lateral disconnection. And lateral disconnection consists of following not only the collateral eminence, but also aspirated the para-hippocampal gyrus and coagulation of the hippocampal arteries. So now the video. Here we see the inferior choroidal point. Now we are performing the disconnection in the collateral eminence. And under the hippocampus, we are going also to aspirate the para-hippocampal gyrus. After this, we have room to mobilize the hippocampus and open the choroidal fissure. That's the next step of our resection. So the next step is the amygdala removal. And here we see the inferior choroidal point that we are going to use as a landmark. And the peeling of the superior temporal gyrus is extended anteriorly and medially toward the uncus. And when the apex of the uncus is removed, we can identify the third nerve behind the arachnoid membrane. The amygdala forms the roof and the anterior wall of the temporal horn, and it lies superiorly and medially to the head of the hippocampus. It's relatively easy to identify the resection. However, its superior limb is more challenging, so we use the inferior choroidal point as a landmark and the bifurcation of the carotid. Here, anatomical dissection to show where the third nerve is close to the apex of the uncus. And the inferior choroidal point is located just posterior to the head of the hippocampus, anterior to the lateral geniculate body. And the carotid choroidal line, modified carotid choroidal line described by Professor Wen, is a useful landmark to avoid injury to the globus pallidus, as it defines the superior limit of the resection. This is a line that comes from the inferior choroidal point towards the bifurcation of the carotid. Other landmarks that may be useful that can ensure a safe removal of the amygdala is even the optic tract or even the arachnoid that covers the uncus. The last part, splitting the choroidal fission and posterior disconnection. So The choroidal fission is open, posterior to the inferior choroidal point, following the tenia fimbriae, and we try to preserve the arachnoid under the hippocampus. So we are going to locate the intraocular point and coagulate the arteries that are going to the hippocampal arteries, but you must be careful with the arachnoid membrane. Here, there is a lesion of the arachnoid, but we try to preserve it, opening the choroidal fissure. The lateral geniculate body may also serve as a posterior landmark for the stent of resection. The posterior extent of the resection. We may identify the body and the tail of the hippocampus. This represents the final step of our resection, and the remaining of the parahippocampal gyrus is removed, the posterior disconnection. And just a review of the hemostasia and the final view after the completed removal. So the final view of the completed removal of the hippocampus and parahippocampal gyrus, we may identify beneath the arachnoid membrane the third nerve, the anterior choroidal artery, the crus cerebri, and the posterior cerebral artery, the segment P2A. You may also identify the optic tract or the lateral geniculate body. This image shows the postoperative MRI 3 months after the surgery. So I think that with this, I conclude the topic I set out to discuss today, and I'd like to thank you again for the kind invitation.
Thank you so much for this very interesting presentation, Dr. Leila. Now I ask the audience and panelists if they have any questions, and so we can open for discussion session. So Dr. Leif or Dr. Ben, if you have any questions or comments regarding these three speakers' presentation. Dr. Leila, I have one question, if I may ask.
Yes, for sure.
To my understanding, by the presented videos, surgical videos, you showed us the resection of anterior and medial temporal lobe, covering the amygdala and hippocampus. So it's basically the selective amygdala hippocampectomy, yes?
In fact, we remove the anterior part of the temporal lobe. So it depends on each case. If we have MRI that the temporal pole has a dysplasia or something like that, we remove more of the temporal pole. Sometimes if it's just medial temporal sclerosis, we remove only the superior temporal gyrus and just the tip of the temporal pole. And
Okay.
during the years, we decided to remove less.
Because I cannot quote or cite any the article I read. I cannot remember the authors, but I have read that some of the authors claim that anterior temporal lobectomy versus selective amygdala hippocampectomy having some different results, and more dominant towards the anterior temporal lobectomy, which they are proving by covering more area of the pathological triggering zones of the temporal lobe and
Yeah,
sclerosis.
in fact, I would say that our technique is not exactly a selective amygdalohypocampectomy. We remove a little bit more than just selective amygdalohypocampectomy, but yes, in the papers, we have better results in the when you remove more temporal lobe, but we have also some more deficits in the neuropsychological tests after the surgery. So I would say that each patient should be evaluated differently, and we decided which technique should be used in each case. But in general, we perform a more selective neocortectomy than we used to, but it's not only the what we call the selective amygdalohypocampectomy that we perform. It's a little bit more extended. We remove a little bit of the temporal neocortex.
So it's case by case decided.
Yes, it's decided case by case.
Okay. Dr. Raja, you have question?
Yes,
Go
of
ahead.
course. First of all, let me thank all the wonderful lectures organized by the Rhoton Society, and it has been great to watch all these beautiful descriptions of the things that you read in Rhoton. Actually, my question is to Dr. Rose because she showed this beautiful surgery for medial temporal lobe. I would like to concur with Dilshot that I think you may have removed more than what is actually required, because our recent speaker was Professor Takahiro Uda from the Osaka Metropolitan University, and he showed us the amygdalohypocampectomy with a keyhole approach, only a single incision instead of a large craniotomy, and he could, at the end point, he could demonstrate everything which you showed at the end of your surgery. And one question that I would like to put across to you on the dominant hemisphere, do you do amygdalohypocampectomy? Because some places, in some people are reluctant, they would offer some other surgical procedures in the form of a vagal nerve stimulation or anything else. So because of the fear of a cognitive decline post-operatively, what is your experience in this regard, especially with people with high IQ?
Well, in patients with hypocampus sclerosis, is really safe when you have only the left hypocampus sclerosis. When we are in doubt if the patient has a compromised the right hippocampus, we submit the patient to WADA test. That is a test that we can see the lateralization of the language, and if there is a functional reserve of the right hemisphere to the removal. In patients that the epilepsy started really in young age, in general, they have no great deficits after the amygdalohypocampectomy. I had one patient that after the surgery, she had a kind of anomia to objects, but 3 months after the surgery, she had a great improvement, and she came back to work and everything. So I think if the investigation with the neuropsychological tests, and if there is a suspicion of involvement of the other hemisphere with the WADA test, it's safe to remove the left temporal lobe and the hippocampus.
Thank you. Thank you very much.
Thank you. And do you use functional MRI in each case of dominant side of the temporal lobe sclerosis?
We are not used to use the functional MRI as an investigation. We use it in some cases, but we still use the WADA test when we are in doubt.
Okay, fine. And we have also a question in chat box who's asking, Julius Hermanto asking, Dear Dr. Leila, in case of temporal lobectomy, with dominant hemisphere and preserved language function, is hippocampal transection is an option, or you still go for resection? I think you have answered this question, or you may complement if you want.
Well, I have no experience with the hippocampal transaction, but as I told you before, the investigation for these cases, I think there was only one case that we did not indicate the left resection of hippocampus because the patient performed really bad in WADA test. So, but most of the cases when we performed the WADA test, we had a good improvement of the seizures and evolution after the surgery with no big deaths after the surgery.
Okay, thank you so much, Dr. Leila Darroz. And if from the panelists and audience has any questions, Professor Kato, maybe you have any comments? Yeah, Carolina?
I do.
Yeah.
If I may, of course, once we reach a mastery point, we can do procedures in neurosurgery any way we want, right? But medial temporal region surgery has a very long and steep learning curve. We have to learn the anatomy, transmute the anatomy to the MRI, to the imaging of our patient, angiography, whatever we use, and then bring that back to the OR and perform what we want to do. We are always very careful in the International Rhoton Society to state that to do safe surgery, we need to know what we are doing, why we are doing, what are we going to remove, and analyzing that afterwards. So I know there is a very high level of mastery in ACNS, but we are always careful to highlight the needs for those who are starting with the specialty, right? Not to be giving hindrances instead of facilitating their life in neurosurgery. Thank you.
Thank you. Valuable comments. So does anyone have any questions? If there are no questions, we can switch to the next speakers. Professor Vincent G from Mount Elizabeth Hospital, Singapore, talking about unruptured aneurysms. Professor, are you here?
Yes, hi. Good evening, everybody. I'm here. My topic today is really talking about management of unruptured aneurysm. Just give me a moment to start sharing my screen. Thank you. Okay. So really, I'm a cerebrovascular neurosurgeon and I have a little bit of hybrid training. So one of the main problems we see in our clinic is that we do see quite a lot of unruptured aneurysms nowadays, especially when we do quite a lot of routine MRIs for stroke screens, for headaches. And the question is really, how do we treat and all that? I think with the group here, I don't really need to explain the anatomy of the aneurysm itself, but as for the audience itself, really the wall anatomy is really different because it's actually very much characterized by the disrupted of the internal elastic lamina, the thinned out of the media, and then the disruption of the endothelium itself with malmodeling of the collagen itself. And it's really a combination of the wall factors plus the hemodynamic factors itself. This was very well illustrated by Professor Takaoka on the actual pathology that starts with the hemodynamic factors of the blood flow, instituting various inflammatory changes that comes down and orchestrated through the endothelium cell itself, with the subsequent degradation of the extracellular matrix, with the whole cascade of inflammation from the formation of the intracranial aneurysms. The current questions of whether the aneurysm will rupture, we know that the mobility of the aneurysms is of an aneurysmal rupture is significant. But the various studies we know, and there's the ICU study in 2003 really tell us that the rupture risk is, especially for small aneurysms, is really relatively low. And this is supported obviously by the Japanese UCAS study group itself. And the question then is really, what are the risk factors that is associated with the rupture of the aneurysms? And these are it's largely characterized by the patient factors, the gender, the age, the history of hypertension, and then the location of the aneurysm, and obviously the size of aneurysms. And that's the historical background of what we do. When we look at the clinical risk factors, then hypertension, age, the smoking histories, and a whole host of this tell us what is the pathophysiological development of how it initiates the aneurysm formation and leading to the progression of the aneurysm itself. When we look at the aneurysm risk factors, the RICO study at the time for all studies will then look at the various factors that we have from the aneurysm, plus the morphology of the aneurysms we have. Putting all together, plus all the latest morphological aspects of what it means by the aneurysm, characterizing it from the diameter, the maximum height, the perimeter dome height, the aspect ratio itself. What I like about this summary slides is, in general, this is what currently guides us our clinical practice, where we tend to use the FACES score with on the various factors that you see here: population, hypertension, age, size, history of previous aneurysmal SAH, the location, with fairly well precise clinical scales for predicting rupture aneurysm, the elapse for the growth, and then whether you should consider treatment is really by the healthy consensus of the UI-ATS score. And this neatly summarize what are the current clinical scores that we use. And surrounding it really will be the various factors that I consider looking at the aspects of the aneurysm, be it the aspect ratio, the size ratio, the maximum diameter, and the various other factors that you see here. I'll talk a little bit about the aneurysm wall enhancement with the and the other morphology changes such as multiple lobes, starter sacs, and all that. Now, this is very nice, and you can now do that very nice put up on this website, the IIS score, where you can calculate all the scores at the same time by keying it on the website and use that regularly in order to do that. That's really looking at the rupture risk based on IUCO, UCAS, UIATS scores at the same time. What is new compared to the previous score was a paper that came out on this MARTA score, which was quite interesting in my mind, where you can see two major factors that you can put in and input on their website itself, where you can look at the patient's factors of all this and the various morphology and treatment pathology of this, and what the outcome of this whole treatment is. It gives you an estimate based on the study on what are the associated risks of treatment of these unruptured aneurysms. And it probably augments the second part of the risk assessment, not only where you're looking at either the patient's pathological factor, epidemiological factors, the aneurysmal factors itself. Now you do have the treatment risk. Of course, that is really based on the modeling and how they created this model itself. The question will be whether it's externally validated to your particular center. But it does give you a little bit more factors for you to consider. I think most of us will be already familiar with what it means by computational fluid dynamics, where we look at the hemodynamic factors surrounding the aneurysm and trying to characterize on the various factors from the physical principles of that in order to see whether this gives us more prediction modeling on whether the aneurysm has a high risk of rupture or even the changes in the morphology of the aneurysm pre and post treatment in both in the endovascular method or the surgical methods itself, to see whether that whole hemodynamic changes with CFDs. The trouble with CFD is that it is really highly technical, and you do need a very well-trained physicist behind and based on your model to be able to work out the complete modeling itself. And there's a whole range of factors that you can look at within the unruptured aneurysms. And it is difficult then to apply it in a full manner, whether it's at this moment still difficult for it to be commercially available, because you need to know and understand the patient-specific implications of the CFD. All right. So the other interesting theory with the advance of the CFD factors is then it looks at whether with the high washer stress, there's two groups of aneurysms that was discussed, and one group where you have with the high washer stress of the aneurysm leading into the development of aneurysms from the mural cell pathway itself, causing small blebs and degeneration. On the other cascade is where you have aneurysms with the low washer stress, and yet they are pro-inflammatory and leading to one of those giant and more large thromboembolic kind of aneurysms with thrombus inside and with the inflammatory pathways, leading to two kinds of morphology of the aneurysms that we see, which I think it's very interesting to give you a background on why do we see different kind of aneurysm morphology when we actually do go into theater to clip it. To recharacterize, moving away from CFD itself, one of the more modern way of looking at the aneurysm is to see whether gadolinium enhancement of the aneurysm wall can give you additional element for consideration whether you should or should not treat the aneurysm. So what you see is that with the abnormal enhancement, there is an accumulative increased risk of growth. Unfortunately, it is still not quite. When I was reviewing the paper was that the cons is it may not still be a full established method of what it means by AWE versus non-AWE, and whether the focal circumferential point is indicates different pathology. This paper that when I was preparing this talk itself, this is the latest paper that come with the aneurysm wall enhancement. And what you can see is that with the wall enhancement, the incidence of rupture and growth-free survival rate drops. And therefore, and this is a very long-term study that you can see that prove that AWE is an independent risk factor for predicting of aneurysm rupture and growth. The next question about what do we do with an unruptured aneurysm? Is there pharmacological changes that we can talk about? And because the underlying pathophysiology is inflammation. So the question will be whether anti-inflammatory medication such as aspirin, although it's obviously antiplatelet effect, may be a promising agent. And we are still waiting for this PROTECT U trial to come in. There are others, basically receptors that or medications that may actually continue to affect aneurysm growth and recanalization. Perhaps one should refer back to this particular paper where it's quite neatly summarized what are the potential pharmacological management of an unruptured aneurysm from a Korean paper itself. And you can see from the various antihypertensive agents, lipids, because it upregulates the eNOS and reduces the inflammation, NSAIDs because of the inflammatory pathways. So this paper actually does give us a fairly good idea of what are the potential candidates as, and most importantly will be really NSAIDs and statins at this moment. Quickly moving on to looking at just now the clinical scales, the CFDs, and then looking at the various pharmacological methods. with the advent of AI, the question is, can we do better in our prediction modeling? And with machine learning, it's getting more and more common that we are doing that. And so machine learning, as just a basic point, you talk about the various supervised learning, unsupervised learning, with the different ways or methods of using that to calculate the outcomes that we can predict, right? And so the idea, therefore, is what I've gone through just now. In the old traditional papers, we were talking about the patient's clinical factors itself. If you're able to put in the hemodynamic factors plus the actual wall modeling that you can do, perhaps that could be something that will be useful in terms of predicting a full aneurysm, whether you can use your model to predict aneurysm growth. And really, it depends on how much information you have to characterize an unruptured aneurysm and how much more you can do in order to put this. I'll just give you a few examples of the various countries. So in this paper is from China, where with their cohort itself, they have a discovery cohort, a derivation cohort of their modeling, and then obviously go on with the validation itself to promote. But the important in this group is the kind of data that you can put in from your modeling itself, including clinical data, radiological data, your follow-up clinical data, and various serum samples that you have from either from the CSF, genetic samples, and we'll cover a little bit of metabolics, right? The idea is that once you are able to do this, the question will be that whether you can use the model you have in order to validate the rupture risk of an UIA and what is the performance of your model. So that's a Chinese paper. This is the latest model that comes from Professor Murayama. And you can see that they too have also in JAMA developed and validated a prediction model for intracranial aneurysm rupture risk. And what you are seeing here is, number one, the discovery cohort, followed by external validation of the cohort itself with the various institutions. And the area under the curve, ROC curve itself, you can see that actually the performance of the MLM model is actually better than the usual prediction modeling that we do with the faces or UCUS. And so that there lie in that perhaps in the future, we will need to actually be able to characterize the aneurysm rupture risk better with machine learning if we have more information at hand of the aneurysm rupture. The paradigm shift seems to be with recently a lot of emphasis in various aspects of gut microbiome. We have talked about the hemodynamic factors of developing aneurysm itself. But what is interesting is there are now also more literature coming up that whether the gut microbiome is associated with the rupture risk of the aneurysms, and just a few papers that have been coming up on whether modifying specific gut microbiome morphology, changing of that may reduce the risk of the rupture. I'll skip that. With the advent of all the Ozempic, Wegovys, and all that, what is interesting is in one or two of the last 2 years, you can still see a host of papers that is now coming up on this GLP-1 receptor antagonist and the aneurysm rupture risk. Mainly not for weight loss per se, because the GLP-1 was mainly first started for type 2 diabetes patient. But what you can see is that it seems to now be associated with a reduced risk of aneurysmal rupture that's coming. So now you see this as well in the GLP-1 receptor antagonist and the outcome for treatment of endovascular unruptured aneurysm. So you could see that with patients who are on diabetic patients who are on GLP-1 RA user, it seems to favor the treatment and with a better outcome of this as well. And this is a third paper that comes in stroke itself from fairly well-known authors. Also looking at GLP agonists with decreased subarachnoid risks in patients with intracranial aneurysm. So with now the world, more and more people are now using GLP-1 receptor antagonists for weight loss. The question really will be whether we are going to see a reduction in the overall aneurysmal risk. So that's something that we should look at from an epidemiological point of view. So in very quick summary, we will always been looking at the rupture risk. And of course, we know that there are different kind of risks in our treatment protocol. And we all know the various treatment modalities we have, be it open surgical or combined hybrid treatment. And all that, which I want, but I just want to go back to this paper, which I thought was very interesting, if you are able to validate, because it will give you a little bit more about the use of this MATA score, which I think is fairly interesting. And very quickly, sorry, I speed through this talk itself, but I hope I've given a bit of a broad overview what is the latest on the literature for unruptured aneurysm. Thank you so much.
Thank you so much, Dr. Professor Vincent. Actually, it's very interesting and very ongoing debates on the CFD analysis and the use of these AI technologies on the benefits of predicting aneurysm rupture. So we thank you so much. And if from the audience, anyone has any question? Dr. Leaf, Dr. Ben, Dr. Zhao, Wang? So if there is no questions, we can move to the next speaker, who is Professor Selvi Oswari from Pajajaran University, Bandung, Indonesia, who's talking about anterior interhemispheric approach. Dr. Oswari?
Hi. How about my voice? Can you hear me clearly?
Yes, we can hear
Okay,
you.
then thank you. And also the screen, I guess I already starting to share the screen. Is it looking okay?
Yes, perfect.
Okay, thank you very much. First of all, my name is Selvi Oswari. I'm from Indonesia National Brain Center. I would like to I'm very honored to be part of the ACNS and the International Rhoton Society webinar today. Today, I would like to discuss a little bit about the anterior interhemispheric approach. So as we know that this technique aims to provide the direct midline corridor to the lateral and third ventricles to minimize the cortical transgression and the seizure risk. And since 1915, Dandy already described this approach. And also Michael Apuzzo, I think he has a very nice book, The Surgical Treatment for the Third Ventricular Tumors, regarding this approach. And Pernesky, Lawton, and Spetzler mentioned about the advantage of the contralateral exposure for the lateral and the third ventricle. And of course, Cushing, Yashar, Sekar, Almefti, Sami, and Professor Suzuki was also the one that's promoting this approach. And personally, I really like this approach. I think this is one of the safest approach to go to the ventricle. As we know, the midline corridor is not an easy area to get into, so that we need to have a strategic plan. So there are several approach that's been mentioned before. It's either the transcortical, but of course it will increase the seizure risk. While if we are doing in the midline and then we split the interhemispheric fissure, then we can spare the cortical and then getting the less risk for seizure, and also going directly to the corpus callosum. And then after opening the corpus callosum, we can then approach to the lateral ventricles. And then sometimes if it's already enlarged, the Monroe, then we can go directly to the third ventricle, or we can also choose either the transfornical or the transporadal. And then we know that there are so many important structures in the midline, which include the hypothalamus. And also if we go down further, then we can find the ACOM complex and also the internal cerebral veins. So this can also have the bilateral access for the both lateral ventricles, and also we can do the vascular sparing, and then we can preserve all the veins and arteries surrounding. And also to do the cognitive preservation, we can do the incision of the corpus callosum about 2 centimeters or less. So the indication usually for the craniopharyngiomas, the hypothalamic gliomas, meningiomas, colloid cysts, maybe that's one of the most common. And for the supracellular cavernous malformation and pure aqueduct tumors. So here's, I really like this diagram, because here in the midline structure, there are several approaches that can be chosen. Either going transfenoidal if the lesion is going further down to the skull base, and then subfrontal, and then going the transcortical or the transcallosal interhemispheric or posterior interhemispheric transcallosal, and also the occipital transtentorial or the supracerebral infratentorial. I think all the midline lesion, it's still very challenging for us. And how to choose, if we then decided to go to the interhemispheric approach, then how to choose which one or which steps that we can be our strategy. So if it's in the anterior part, then we will choose anterior interhemispheric, and then we can either go subcallosal or the anterior transcallosal. Subcallosal means that, and then we can go to transcallosal for the third ventricle. And to approach central, we can go to the interfornicial, transforaminal, or the subchoroidal. But we also anatomical structures that can be approached through the anterior interhemispheric transcallosal. In the ipsilateral part is the medial part of the frontal lobe, and then the ipsilateral of the single gyrus, the frontal horn of the lateral ventricle, the foramen of Monroe, the septal vein, thalamus striate vein, and the caudal plexus. And the contralateral is the opposite side of the single gyrus, and also the lateral aspect of the contralateral ventricle. We will discuss about this further because I think there are some arguments in choosing either we should go ipsilateral or contralateral. And of course, the midline structures is the superior sagittal sinus and also the velum interfacitum, third ventricle, even though we can also go further down to the interpedencular fossa. For the positioning and trajectory, in the approach, usually what is in the first couple of minutes. It's very hard to usually then it's not very easy to separate the interhemispheric fissure. And with here, the standard anterior interhemispheric approach is there's the normal position around 10 to 20 degrees flexion, and then go to the third ventricular axis. But if we want to go further down or further back, then we can do the extreme anterior so that we can go up a little bit more, 15 degree. This is for the patient with the supine position, and we haven't talked about if we want to use the gravity as a retractor, the easiest way would be to turn the head to the itself will help the hemisphere to be retracted. And the size of the craniotomy usually is it depends. Sometimes it's less than 5 × 5 centimeters. And then the landmark, this is the common that's being used. It's 1/3 posterior and 2/3 anterior to the coronal suture, and the dural opening C-shaped based toward the sphenoid sinus, sagittal sinus. Sorry. So here's one of the example on using the head to turn one side or even going lateral all the way. After that, we can choose the craniotomy, depends on the projection. We can go further anterior or going posterior. But the classical way is 1/3 and 2/3 of the anterior coronal suture. And here is the burr hole. You can do the burr hole in the midline, or you can also extend it a little bit to the lateral part, as long as after that we can access easily, and we can, after the dura opening, then we can flap the dura to the medial part. And if we are using, usually sometimes we don't need to, if need, then while separating the anterior interhemispheric fissure, we can do a slight retraction. After the dural opening, then I found that there's the paper from Yi et al. In 2024 trying to classify and how to do the dissection strategy for the bridging vein interface. There's type A, type B, and then type C. And then the type A means that it's a direct bridging vein. And then we know that there are loose connective tissue in between. So then the technique would be to split the loose connective tissue. But if it is type B, meaning that it's adherent, and then the bridging vein, and then we dissect partial the dura or sinus wall to release the tension. Sometimes if it's to attach to the falx, then sometimes we need to dissect a little bit there. The main idea is to preserve as much as possible the vein. And this is the type C. And for the interhemispheric dissection and the callosotomy, if we can, then we will try to limit 2 centimeters to minimize the disconnection syndrome risk. And the location, usually the junction of the genu, to identify the callosomarginal and the pericallosal arteries in the fissure. After that, then we will enter the lateral foramen of Monroe, meaning the transforaminal. But if not, then we can choose either we should go the transchoroidal, or maybe in the old times, transfornicial. But we know that transfornicial can cause a morbidity. So it's better to choose the transchoroidal if possible. Especially for the large tumors, for example, the craniopharyngioma. So after we dissect the bridging vein, and then find the callosal marginal, this is the picture from the cadaveric dissection. Then we find where the corpus callosums are, and then we enter the lateral ventricles, and then we identify the fornix, and then the choroid plexus, and then also foramen of Monroe, and then the thalamus. And then if we want to go to the third ventricle through the transchoroidal, then we choroid plexus medially, and then we open the velum interpositum. And in 2021, Borekci and Haznezi present a case study about the cholecyst of the third ventricles, and it showed that with a limited callosal incision, less than 15 millimeter, they can preserve fornix and also the septum pellucidum, and then they can do the total removal 6 out of 7 cases. How about the possible complication that might happen? Then we need to prepare beforehand, the pre-op phenogram, and then we need to identify and classify the bridging veins, either the type A, type B, and C, and we know the strategy for each type. And then identify the ACOM and the pericallosal arteries, and then dissect in the callosal cistern. And the callosotomy, if possible, needs to be less than 2 centimeters, and trying to do the minimal retraction and trying to use gravity as our friend. So we can go, usually it's better to choose the contralateral approach, because then we can go directly to the contralateral side of the extended tumor itself. And with the gravity, then the cerebrum, the hemisphere, will give us a way directly to the interhemispheric fissures. And this is what we should aim, minimal footprint to the brain. I think it's correct to all surgeries, but especially in the surgery, because we actually going into the interhemispheric fissure, it's a normal fissure, then it means that we should not cause too much damage to the brain while entering the midline structures. Okay, so here are the examples. I think for the young surgeons here, one of the most devastating, usually in the first couple of minutes, because trying to separate the fissure, maybe it can be a bit struggling, because if the anesthesiology was not relaxed, and also if it's high ICP, then it will be very hard to dissect. There are a couple of times when I did this with several surgeons. Some of them usually mention that, doctors, I don't think this is a good way to go. Maybe we can just go through the corticotomy, and then it's okay to increase a little bit risk of seizure. But actually with patients, little by little, trying to dissect all the veins and then the arteries in the interhemispheric fissure, I believe that this is the best way to go to the midline structures. So here we can see that there are so many veins that we need to dissect beforehand inside the fissures. And then when we find the whitish structure like this one, then we know that we are already in our area, that we can also try not to dissect in the lateral side of the both pericallosal arteries, so that we can only separate in the medial part, so that with that strategy, that we can, it also can help us to make the pericallosal artery not in our way. And then we do the corpus callosotomy, and we know that when we open the lateral ventricle, some of the CSF will come out, and then usually everything will be relaxed here. And then we try to identify the tumor. Usually, sometimes the tumor already extended to the lateral ventricle here. And we try to find the border with the lateral wall of the lateral ventricles. And then doing piecemeal would be suggested in this area. And then after it's become thin, the capsule, then we can try to dissect it, of course, with the help of the intraoperative neuromonitoring. And then here is the after surgery. I just want to show that with this approach, we don't actually, we are trying very hard to preserve either the cortex or also the arteries and vein in the surroundings. This is a case for third ventricular craniopharyngioma. We know that there's also some guideline for the pure third ventricular craniopharyngioma that actually push the third ventricle bottom to below, then it's better to choose the approach from the anterior interhemispheric instead of trying to go either from the endoscopic approach or also from the lateral approach. It can be done, but it will be easier and also straightforward if we are using the anterior interhemispheric approach. Here we already dissect the anterior interhemispheric approach, and then we found the corpus callosum, and then we try in the beginning to do the corpus callosotomy, but we know that we already plan if we need to extend our corpus callosotomy, then everything already dissect anterior part and also the posterior part, because sometimes what happened is that when we do the retraction, then usually the anterior and the posterior part that's not yet released, it was the one that causing trouble. And here we can see the craniopharyngioma, the tumor itself, some calcification, and then we try to do a very low coagulation. And when we want to do the coagulation, we try to put it away from all the lateral part, because we don't want to damage all the important structures in the midline structures. And with those guidance, the intraoperative neuromonitoring, the navigation, after that we can remove most of the tumor. But then here in this part, when the intraoperative neuromonitoring already shows some changes because it's very attached to the third ventricle, then I usually decide to stop, and then in the end I usually put the EVD afterward. So here's the post-op patient, the scan, and this is the patient. I think it's about 1 month after the surgeries. And the pathology is the adamantinomatous craniopharyngioma. And this is just another example on how to perform this. In this patient, I did the lateral position so that I really want to use the gravity to help during surgeries, so that I can have less struggling while trying to dissect the interhemispheric fissure. Yeah. Okay. Okay. So there aren't that many presentation, I guess, about this anterior interhemispheric approach, which I personally think that it's one of my preferred approach for the midline structures. So I really think that this is a very important approach to be learned during the during training, because then we know that even though the lesion is in the midline, we can still safely and going to the approach without causing more morbidities. Thank you very much for the opportunity.
Thank you so much, Professor Salvi Oswari. This is a wonderful presentation of it's a well-known interhemispheric approach, which is very useful and versatile in many cases. So we have one speaker left, the last speaker, Professor Vairavan Narayanan, Faculty of Medicine, University of Malaysia, who's talking about intraoperative electrocorticography guided precision resection of epileptic lesions. Professor?
Hi, Dilshad. Thank you very much. I hope
You're
you can
welcome.
hear me. Is And my PowerPoint is it clear?
Yes,
Okay.
it's fine.
Thank you very much. Thank you to the ACNS team, Professor Kato and everyone for having me here, as well as the International Rhoton Society members. I think it was a very enjoyable initial lectures, especially from Professor Martins and De Ross and Craig-McQuaide. I myself am my special interest is in epilepsy surgery, so I found it very informative. Thank you very much. I'm going to be talking a little bit about a very specific area in epilepsy surgery. This is basically intraoperative electrocorticography guided precision resection of epileptic lesions. Primarily because epileptic lesions are electrocortical lesions, and their boundaries are not necessarily defined by purely anatomy and radiology. And in this case, the electrocortical margins are very important to attain good outcomes. So I'll be talking about this technique, which I've been actually doing for the past 6 years. We'll talk a little bit about the evidence, technique, and implementation. So the main objectives of this talk is going to cover the definition of electrophysiological basis of ECOG, the pathological margins of uncertainty, the evidence available for ECOG usage, the technique and clinical application, as well as advances and limitations. The main problem here is the margin of uncertainty. And this is mainly due to the fact that primarily the defined margins are usually based on, for us, when we talk about pathology, is always based on MRI preoperatively and intraoperatively anatomical boundaries. Unfortunately, when it comes to epilepsy, there are enough lesions, especially focal cortical dysplasias and other MRI negative neocortical lesions, which are only defined by electrophysiological boundaries. And that's where electrocorticography can come in to help us. There are 4 main pathologies which is actually primarily useful. This technique is primarily useful in. Number 1 is focal cortical dysplasias with blurred MRI margins. In this case, the challenge is primarily where does the dysplasia end? And ECOG is used to define the irritative rim beyond the visible lesion. The second pathology is low-grade epilepsy-associated tumors with perilesional gliosis. Again, the challenge is to define the epileptogenic tissue from the tumor tissue itself. And electrocorticography, again, can be used to tailor our resection. And the third lesion is MRI negative neocortical epilepsies, where there is no surgical target visible, either in the MRI or in anatomical visualization. And in this case, the ECOG helps us localize and confirm the completeness of resection. And finally, in posterior quadrant lesions, where the challenge is to preserve visual pathways, the ECOG is able to help us set lateral margins with functional verification. So these are the main reasons we can use intraoperative electrocorticography to help us define the lesion and resect the lesion with minimal morbidity. So the main goals of intraoperative ECOG, as I mentioned, is to refine the epileptogenic zone before and after the first pass resection, to tailor neocortical margins, decide on mesial structures in temporal cases. This is especially when there is temporal lesions which may or may not have a network connection to the mesial temporal hippocampal structures. So the question becomes, do I want to resect the mesial temporal structures along with the neocortical lesions? And ECOG can help in these situations. To confirm post-operative completeness of resection, and finally to identify eloquent cortex, whether it's motor cortex or language and cognitive functions, by extraoperative ECOGs with direct cortical stimulation. The main aim is, as I mentioned, to balance good seizure freedom with minimal functional deficit in all cases. This is an example of an MRI with a focal cortical dysplasia, and we are able to see in this case basically area where the crosshatch is a small focal cortical lesion. While it's clear in the MRI, intraoperatively, this looks absolutely like normal brain. And the margins are usually difficult to visualize or to appreciate. And that's where ECOG can actually help. Similarly, this is a posterior occipital lesion, focal cortical dysplasia again. While it is clear on the flare lesions, intraoperatively, it is indistinguishable from normal brain. The main electrophysiological basis here is utilizing the signal hierarchy. And in this case, the ideal signal will be an ictal rhythm. Unfortunately, this ictal rhythm, which has got the highest sensitivity, is rarely captured intraoperatively. Patients don't seize very easily once they are under anesthesia. So it's very difficult to get an ictal rhythm in this case. On the other hand, the rhythm we usually get is an interictal spike at 1 to 60 hertz. And this is usually what we use to guide our margins. It has got moderate specificity. We do have other types of rhythms like spike wave complexes, which are a higher seizure onset zone yield and has got better localization value. Similarly, the high frequency oscillation ripples at 80 to 250 hertz can be used as adjunct. And finally, the 250 to 500 hertz high frequency oscillation fast ripples are an excellent ictogenic marker. But these are all emerging rhythms. The standard rhythm we use in most cases is the interictal spikes to guide our margins. And you must remember the interictal spikes on once the ECOG is used has got a 10 times higher spatial resolution compared to extraoperative EEG recording. There is a recent 2024 paper by Van Kloster, which actually talks in detail about the fast ripple guided resection, which is not really necessary to obtain the most optimal outcomes. In fact, the paper actually redirects our focus to patient selection and technique refinement as the main identifier for good outcomes in patients. The evidence for ECOG's electrocorticography spans more than 60 years. It was first started by Forster and subsequently modified by Penfield with intraoperating mapping principles. And it has been used on and off for the past 50 odd years. But it's only in about 2010 when a larger group of surgeons adopted ECOGs, intraoperative ECOGs, and utilize them intraoperatively. And this led to a growing evidence base. And finally, in the last 3 to 4 years, there's been a lot of publications on the utility of electrocorticography and the detection of abnormal rhythms and their value in operative resections. The standard algorithm is if a lesional epilepsy is identified on MRI and the margins are clear, then we would proceed with anatomical resection. However, if the margins are unclear, especially on MRI, then you would want to consider either an SEEG or a ECOG. An SEEG is usually considered when it's a network or distributed epilepsy, while an ECOG is considered if it is a discrete lesion in a single area with no network involvement. In classic mesial temporal sclerosis, an ECOG does not really add much benefit. But if it is a more complex or extended mesial temporal sclerosis with neocortical extension, then an ECOG may help for completeness of resection. Of course, as I mentioned earlier, if the epileptogenic zone is expected to be a distributed network, then an SEEG works much better than an ECOG. So the technical standards are in a very basic form: map, resect, and remap. The baseline is always place a grid or strip with once the anesthesia is stabilized, and do a 2000 kilohertz sampling with a propofol pause protocol. This is usually done for at least about 5 to 10 minutes. And once this is done, a first pass mapping is done, where both the anatomical and perilesional resection is performed with concurrent central sulcus mapping if it's near eloquent vicinity. Finally, once a first pass resection has been done, the patient is remapped. And this time, a post-resection ECOG is done to identify any residual spike rhythms. In this case, depth electrodes can sometimes be useful, especially if the lesion is of a very abnormal shape. Because you must remember, a depth electrode itself doesn't conform very much to abnormal shapes. This whole map, resect, remap is then iterated multiple times until we reach a point where there is electrophysiological quiescence. And this may be as simple as a single cycle to I have done up to about 8 to 9 cycles if necessary. And there must always be safety protocols, including after discharge monitoring, because we are constantly simulating patients. They can go into status epilepticus, so there must be a continuous EEG monitoring. The direct electrical current must be done in an incremental phase, stepwise. There must be cooling irrigation available, especially if seizure is detected, as well as benzodiazepines if necessary. There are certain critical success factors, including the propofol pause protocol. This is probably the most important reason why this technique does not work if propofol is not paused early enough. And sometimes we may, instead of propofol, you try to use other agents like dexmedetomidine, which actually is better in these cases because you can actually turn it off very quickly. Similarly, I think you need to have depth electrodes because they actually help, especially in sulcal, temporal, or deep-seated lesions. Every step of this first pass and remapping and iteration must be photographed so that we know exactly where the lesions have happened and what happens at the next level. And this iterative philosophy actually helps in getting better outcomes. This is the University of Malaya series. We have done 26 cases between 2019 to 2025, and as expected, the Engels outcome of 75%. This is not a standard epilepsy case. These are all the either MRI negative lesions or a extended extratemporal complex epilepsy lesions. So we have got 75% Engels 1 outcome for low risk cases in temporal regions for low-grade tumor-associated epilepsies, as well as discrete lesions. In medium risks, which are usually in the frontal, occipital, and parietal areas, the Engels outcome is 58% for Engels 1, while in high-risk cases, these are usually in the eloquent area involving motor, sensory, language areas, language especially, and is frequently deep or sulcal in nature. The outcome is actually a little bit more guarded, only 25% Engels 1. The main adjuncts for low risk are usually an electrocorticography depth electrode, as well as electrocorticography surface, as well as a depth electrode. In medium cases, a depth electrode is compulsory, while in high risk cases, I also add on central sulcus mapping as well as subcortical mapping. And the favorable predictors in our series has been FCD2Bs, as well as low-grade epilepsy-associated tumor lesions. Age less than 16, depth electrode usage, and a complete remapping cycle of at least 3 times. The main differentiators for depth electrodes, when we looked at our own series, with the depth, we had a 75% Engels 1, while without the depth, the Engels 1 was only 40%. This is a 35% improvement with depth electrode. Of course, the unfavorable predictors include FCD2A and redo surgeries and incomplete sampling. So for people who are interested in starting intraoperative electrocorticography practice in their own services, usually there's 3 phases to starting this service. In phase 1, you have to make sure you have the correct equipment, which includes a 32-channel amplifier, 2000 kilohertz, 2000 hertz sampling, and a high-density grid access. You must have the correct personnel, which includes a neurophysiologist with intraoperative experience and a surgeon trained in direct cortical stimulation. And preferably your first few cases are proctored by an experienced surgeon. You must have access to the appropriate electrodes, which includes the surface electrodes at 5mm contacts, 1 centimeter spacing, as well as depth electrodes at 5mm spacing. And you must have a good anesthetist who's able to actually wean off the propofol quickly when the actual electrical simulation is started. One among the most critical important factors is the neurophysiologist must be present in OT. This is non-negotiable. They cannot be present remotely. You cannot have technicians. You must have a neurophysiologist available to read in real time the electrocorticographical signals. In phase 2, so the first phase usually takes about 6 months. In phase 2, we usually proceed with the actual simpler cases. As I said, the low risk, medium risk, the focal cortical dysplasias, low-grade epilepsy-associated tumors with clear imaging, and try to avoid MRI negative lesions initially. In phase 2, of course, you want to have as good your aim is to get good outcomes by choosing simple low-risk cases. Of course, in phase 3, you can then expand to MRI negative neocortical cases, posterior quadrant cases, and HFO samplings. Quality assurance framework is very, very important in all these cases. There must be monthly MDT. All cases must be reviewed, and there must be comparison benchmarked against SEG, so that you are always able to improve on your own outcomes. This is a very brief illustrative outcome of a single case, a 20-year-old young man with recurrent seizures since 14 years on refractory to multiple AEDs. The MRI showed a right occipital gyrus focal cortical dysplasia, and the scalp EEG was concordant to the right occipital seizure. This was the lesion on a 3D reconstruction, as well as intraoperatively the lesion. We can find the lesion here. When we initially put the electrode grids in position 1, there was active spikes and polyspikes in the area documented by the circles. This then extended us to enabled us to move to position 2, where we again mapped. As I said, this is mapped multiple times, and finally the extended resection plan was defined according to the black marker all around in the right hand picture. This was then resected initially, and subsequently the grid was placed again for a third. This is in position 7, and the third time we're putting it in. And again, we found that there was still polyspikes in this region. So the extension was then, the resection was then extended further. And finally, what we achieved was in position 8, an extended lesion all around this area. So what we see here is what we started off was the blue marker. We extended to the green and subsequently the red area as well. And this is what the patient ended up with. This is the spikes as seen. The first A is the initial spike. B was before, while we were doing the first resection. C was after the second resection. And D shows the quiescent, no more polyspikes in the final position 8. What are the limitations of intraoperative ECOGs? Residual spikes may be due to irritation and or due to surgical manipulation and anesthesia emergence. So usually you have to wait, give it time, be patient about this whole process. We may always have surface bias because most of these are done with surface electrodes. So deep and mesial sources may be missed by surface grids. It is that's the reason why it's mandatory to have depth electrodes. Anesthesia suppression happens frequently, especially if the anesthesia is not controlled well. And because of this, the spikes may be obscured. We have to have a standardized anesthesia protocol, and the anesthesia must be taken off before we start monitoring in an appropriate timing. There is always the worry about over-resection, trying to chase the spike into eloquent context. So there must be predefined stopping rules so that you know where your limits are, and you mustn't cross the limit once you've already reached there. It's also good to identify the central sulcus before the resection so that you do not cross into motor eloquent areas. If you are suspecting network epilepsy, as I mentioned earlier, SEEGs are much better because ECOGs only capture focal component. They will miss the distributed network. In future, there is quite a lot of research going on about high frequency oscillations. Currently, they're still being used as adjunct, but emerging evidence showed that they allow automatic detection and network HFO coupling. The hardware as well has improved with high density grids. We used to have only 5mm contacts. Initially, it used to be 10mm contacts, improved to 5mm, and now we're improving to 3mm contacts with flexible sulcal conforming electrodes. We have moved from 10 to 30-minute baseline recordings to ultra short 2-minute snapshots, which actually offers almost 85% concordance. And finally, ECOG plus structural imaging integration has actually already happened and actually helps improve our confidence of resection. The important caution to remember here is we must only adopt innovations after local validation. So RCT evidence usually lacks the technical capability. Please be careful. Don't simply jump into the latest new things without local validation. My take-home message is intraoperative ECOGs test your plan. It doesn't replace it. It's the imaging and clinical hypothesis that guides electrode placement. Spike-guided tailoring remains the main reference, while HFOs are only used as adjuncts. The main principle in this ECOG-guided resection is iterative. That means you must map, resect, remap, resect, and remap again. And you do it as many times as necessary until you reach a quiescent state. Depth electrodes are useful in complex cases. As mentioned, our results improve from 40% to 75% with the use of depth electrodes. And implementation requires phased investments. You don't jump straight to phase 3. It's good to do phase 1 simple cases, move on to phase 2, and finally phase 3. I think that's the end of my talk today. Thank you.
Oh, thank you. Thank you, Professor Narayanan. Thank you so much. That was very, very impressive, informative lecture about the use of ECOG in the intraoperative setting. And if you allow, I have one question. So you talked about the stimulation, the frequency stimulation should be around 2 or 4 kilohertz, yeah?
Actually, no. The simulation is usually for standard simulations 1 to 60 kilohertz, 60 hertz. But
Okay.
high frequency oscillations we go up to 500 hertz.
Okay. I was interested because in awake surgeries we use to stimulate a certain eloquent area, 50 or 60 hertz, not kilohertz, but maybe this is something different in the setting, yeah.
60 hertz, 60 hertz and 250 hertz. Yes, you're right. It is 60 hertz.
Yeah. Okay. Thank you. And does anybody has any questions from the audience, panelists, who are interested in and doing the functional surgeries? Maybe Professor Carolina?
I do have a comment. Thank you, Dr. Narayan, for your presentation. I think it's very fortunate that we are all in the same session. So we rounded up the idea for the listeners. Thank you.
Thank you, Prof. Kalina. I mean, I really enjoyed all your talks because it actually, as you mentioned, it rounds up from anatomy to radiology to surgery, and also special adjuncts in more complex cases.
Thank you. And maybe any other questions from the audience? Professor Leaf or Leila? Do you have any questions? So in that case, we will summarize this extensive webinar, which was very successful. Personally, I learned a lot from our mentors, professors, Dr. Carolina, Dr. Leila, and Anna Craig-McQuaide, and of course from Dr. Narayanan. That was very fascinating and interesting, and very dived into details of the use of medial temporal sclerosis surgeries, radiology, and diagnostics setup, and very detailed explanation from the Rhoton Society team, and of course from the Professor Narayanan, which is also a very detailed explanation of the use of electrocorticography and many others. And special thanks to Dr. Vincent, who was also illuminated us with the knowledge of this very interesting topic. And maybe some words from closing remarks from the Professor Kato.
I think today's webinar is very worthwhile, especially for young doctors, I think. So maybe I think in the near future, the anatomy is almost close to the radiology. So because of many of the institutes have a very nice radiology machine, so that it can tell us how much such kind of the stent is close to the inner membrane, or is it enough or not? No need to see naked eye. So maybe we can see by radiology. I think, but anyway, the very fundamental thing is anatomy is very, very important. And Anna tell us very nice, very how close of the anatomy and radiology. That is very important. And also the later is clinical presentation. I think the three talks are very, very high, sophisticated. Maybe you will have the Rhoton Congress in next week, I think. Maybe, I think I heard.
We are joining the Yasagio Academy next week. Yes, Professor.
Yeah,
in São Paulo.
Oh, São Paulo. Okay, all the best, I think. And also the Vincent, thank you very much for your nice talk. I think recently that you mentioned about the infection or some bacteria is related with the aneurysm formation. So maybe I think not only the morphology or radiology, but also in that point make some hints of the treatment of the aneurysm in the future. And of course, the selfie is always a nice talk. It's very fundamental, the interhemispheric approach for many pathology, I think. So this is very helpful for our daily work, and also the Narayana. And thank you very much. Maybe this short will have a lot of the interest of your work. Anyway, the great the webinar. Thank you so much. Rishabh?
Yes. Thank you so much for everybody for actively participating. And I really enjoyed the anatomy explained by the Rhoton Society team. I think it's very reasonable to join the anatomical aspects of the special topic or special lesion. First, giving the anatomical knowledge, and then going to the radiology and going to the diagnostic setup and treatment, surgical strategies. Very much, I mean, the logical sequence is very good, and this is something you gave us very good input, so we can use this kind of technique in the next sessions, or we can join more frequently this kind of webinars. Very much useful, yeah. Dr. Raja, any comments?
Nothing. It was wonderful. Thank you very much, Dilshod, for supporting us and all the wonderful speakers and chairs. It was really good to learn. Thank you very much.
Yeah. Thank you so much, dear friends, dear colleagues. And in this, we hope to collaborate in the next, in the future, more frequently. And I thank you so much once more again. Bye-bye.
It has been a joy for us at the International Rhoton Society. Thank you, all the friends, very much.
Thank you.
See you all
so much.
See you all. See you. Bye-bye.
So Carolina, maybe some Japanese will join.
Thank you.
Yes, yes, Professor, anytime.
Yeah.